All right. Thanks so much. My name is Annukka Antar, and I'm from Johns Hopkins. I was able to speak to you yesterday, introduce myself. So I'll just move along. There's nothing to disclose. So today I want to share with you work that we've done on cortisol as a biomarker for long COVID. So this really came to the attention of the community with two landmark papers that I'm showing you here. The first on the left was published in Cell in early 2022. So here they measured plasma concentrations of a variety of proteins at diagnosis of acute COVID-19, during acute disease, and then 2 to 3 months post-infection. And of all of this proteins that they studied, cortisol and cortisone were among the top that were significant. So I'm showing you that on the top left. I don't think I have a pointer here. So that's the top left of the left side. Do I have a pointer? I don't. Okay, thank you. So among the people who at 2 to 3 months post-COVID had symptoms such as cough and fatigue and shortness of breath and chills and muscle and body aches, cortisol and cortisone levels were lower than people who didn't have those symptoms, and then healthy controls. And then right next to it on the right, those two boxes on the right show that the people who had more symptoms at 2 to 3 months compared to less symptoms at 2 to 3 months had lower cortisol and cortisone. And then on the bottom series of panels, they're showing that, so they were wondering if this was a product of people getting dexamethasone if they were hospitalized and requiring oxygen, because dexamethasone will suppress your endogenous cortisol and cortisone levels. And so they examined whether it was driven by that here on the bottom. So in red is the group of people who did receive steroid treatment during their hospitalization, and green were people who did not. And so at time 1 and time 2, they do have lower cortisol and cortisone levels, but that's not significant at time 3. So showing that this seems to be an effect that's independent of receiving dexamethasone in the hospital. And then I think most everyone is familiar with the Klein et al. Paper from Akiko Iwasaki's group. I'm showing you here on the right, and this was even shown by Jeannie Marazzo yesterday. And so in this study, they measured multiple immune parameters and hormones in people with long COVID and controls. And this time point was later, so instead of 2 to 3 months post-infection, it's about 12 or more months post-infection. And they found that among all the features that they had, low cortisol levels was the strongest feature in their parsimonious biomarker model of long COVID. They measured ACTH in the blood. So in work I'm not showing right now, they measured ACTH in the blood, which is the hormone precursor that stimulates cortisol production. They found that to be similar in long COVID and controls. They looked at time of day of collection, and I'll kind of get into that later. So they did find the time of day collection was a little bit later in the people with long COVID, and that was statistically significant. But then they did modeling work and showed that long COVID status was actually kind of a stronger effect than the time of day. They mentioned that they removed people who were known to have adrenal insufficiency and recent oral steroid use from the analysis. So together, this is pretty strong evidence that low cortisol levels associate with long COVID at 2 to 3 months post-infection and 12 months post-infection. So this is very intriguing. And then even more intriguing, so there's some work, and I'm showing you here a study in ME/CFS. So here they took 20 people who were homebound, and most were bedbound with ME/CFS compared to 10 controls, and they looked at cortisol levels throughout the day, and they found that morning cortisol levels were lower in people with ME/CFS. So this is an attractive hypothesis. I personally was very excited about this. So there's many reasons why this could be biologically plausible. So the first is that so to back up, cortisol is produced by the innermost layer of the adrenal glands, the adrenal cortex. So number one, the adrenal glands, they're highly vascular, and some pathogens, because they're so highly vascular, they receive the largest blood supply basically per kilogram weight in the body. And so certain pathogens, and as examples, TB, histo, gonococcus, CMV, are known to infect the adrenals and can sometimes cause adrenal insufficiency. Many symptoms of adrenal insufficiency overlap with long COVID symptoms, such as weakness and easy fatigability, cognitive difficulties, poor quality sleep, and GI problems. And those are also reported in long COVID. And then adrenal cortical cells do express the viral receptor and the co-receptor ACE2 and TMPRSS2. And then there's been at least 6 autopsy studies, including dozens of people, showing evidence of SARS-CoV-2 infection and adrenal damage. So just showing you one of the series here on the bottom left. The left panel is showing ACE2 immunohistochemistry, the middle is TMPRSS2, and then the right is SARS-CoV-2 protein. And then that right panel there is showing disruption of zonation, so in adrenal glands, so showing you fibrosis and damage to the adrenal cortex. So to pause, these are people who died of acute COVID-19, so this might be different. There might be less damage, of course, in people who survived COVID-19, but this is an example that it can cause adrenal damage and infect cells directly. Now, the 2 studies that I showed you, they relied on blood samples that were taken randomly throughout the day, just whenever a participant could come into clinic. However, that's not a great indicator of cortisol secretion or adrenal function. So as shown on the left there, there's a peak of cortisol production either just before or right after awakening. That's called the morning awakening cortisol response. And after that, levels of cortisol fall pretty rapidly and then slowly throughout the rest of the day, and they nadir in the middle of the night. So these levels actually mirror the levels of ACTH, which also is secreted diurnally, and they also peak just before or after awakening. So on the right is a kind of a cartoon of the hypothalamus pituitary adrenal axis, the HPA axis, in which the hypothalamus produces CRF, which stimulates the pituitary gland to secrete ACTH, which then stimulates the adrenal cortex to produce cortisol, among other adrenal hormones. So how the adrenals are typically tested clinically is not by just drawing a random cortisol in the middle of the day. So one test for the main clinical test for adrenal insufficiency is to do a cortisol stimulation test. So this is where you give exogenous ACTH as an injection, and then you measure in the blood the amount of cortisol that's produced by the adrenal glands in response. And then another way to investigate cortisol is to measure it at its peak, just kind of at the time of waking up, and then you can also test it at its nadir throughout the end of the day if you're worried about hypercortisolism. So good studies have shown that salivary cortisol is really tightly correlated with the amount of free cortisol in your blood. So the amount of free cortisol, that's the bioavailable cortisol in your blood. So both clinically and in research, we can test salivary cortisol as a measure of free cortisol. So that's just a note for later. So we had 2 research questions. One was, we at Hopkins had these 2 large cohorts of people who were with COVID and in their recovery over 1 to 2 years. And so we wanted to know, could we replicate the results in our studies? So were there lower cortisol levels in people with long COVID compared to people with full recovery in our cohorts? And then we wanted to measure cortisol kind of in a standard way and kind of properly. So we wanted to know, do people with long COVID truly have adrenal insufficiency, or do they have different diurnal patterns of cortisol secretion throughout the day? So I'm showing you here work that we've done. So we had a combined total of 381 participants and over 700 samples, blood samples, and we sent them all kind of at the same time to a lab at Hopkins to get total cortisol levels. And what I'm showing you here is kind of months 3 through 12. I'm trying to approximate the time periods in the 2 papers. And on the left side are people who have long COVID, kind of by our survey definition at that time. And then on the right are people who never have long COVID at months 3 to 11. So we don't see any statistically significant differences there. We parsed this out in many ways. The one way that was significant, although it was significant only when we did not correct for multiple comparisons, was this one on the right. So month 12 only, you can see we have fewer samples of people who had long COVID at the moment, and the people who never had long COVID, there was a difference. However, more than half of the long COVID participants were taking glucocorticoids in some form or another, whether it was inhaled or something else. So it was kind of difficult to tell if this was really due to long COVID or whether it was due to the medications that people were taking. One clear trend we saw is that cortisol levels do wane throughout the day. So it really is important to take into account the time of day that it's drawn. And then we shamelessly borrowed from the UCSF Link cohort to do this kind of study where we're looking at the different times of day that the cortisol of the blood is drawn and trying to see if we see any differences. So again, these are people between now months 1 and month 12, people who are symptomatic at the time and have long COVID at some point versus people who never have long COVID. and we see no statistically significant differences at any of these kind of time windows. So, so it looks like in our study, at least, that testing a random cortisol level in the clinic probably would not be a great biomarker, at least in people who were like the people in our study, people who were never hospitalized and who had kind of mild to moderate long COVID. So then we wanted to look more closely and more detailed in a more detailed way, and so I teamed up with Amir Hamrahian, who's the medical director and an endocrinologist at Johns Hopkins. So he runs the Hopkins Comprehensive Adrenal Center. So I worked with him to make sure that we designed a study that was going to accurately measure, adrenal function. So we enrolled people, and we also wanted to enroll people who had really significant limitations from long COVID. The two cohorts I was describing before, there are some people who have significant limitations, but most people probably, have long COVID, but, are still working and things like that. So we wanted to enroll kind of more severe people. So we worked with Alba Azola, who is here at this program because she runs, she co-directs our long COVID clinic. And so we enrolled those people, and then we found controls who recovered completely within 6 weeks of acute COVID-19, and then we roughly matched the groups on age, sex, BMI, and then date of first SARS-CoV-2 infection. So we wanted to have people who were all kind of infected around the same time. And then the most important thing that what we did was that we really wanted to test this in isolation, separate from people who were taking glucocorticoids. So participants could not have taken any glucocorticoids in any form. So, no Symbicort, no inhaled, no topical, no oral, no Hemorrhoid cream, nothing for at least the past 4 weeks, and then no injections in the past 3 months or sooner. So. We did ACTH stimulation testing in a smaller number of people. This was limited by our funding, but in 34 people, and then in 100 people, we did diurnal and morning salivary cortisol levels, and both were split. And I'm showing you a picture of Armand Jamal, who's a fantastic tech and study coordinator, who's been the main person working with me on this. And then we also did comprehensive cognitive testing by telephone and also in person with help from kind of our neuroscientists, Tracy and Sherry. So I'm showing you just the consort diagram of people, kind of where they came from. So in the long COVID clinic, most of our participants were referred directly from the long COVID clinic, but we also spread the word on social media and listservs. And the big thing I want to point out there is who was excluded from the study because they were taking glucocorticoids in one form or another. So if you look, we started with roughly similar numbers of people contacting our study or us contacting them. But 69 people who had long COVID could not be part of our study because they were taking glucocorticoids versus 8 in the COVID recovered. So just to show you that a lot of people are taking glucocorticoids because they have shortness of breath, and that's a normal thing for them to do. But it also reminds us that these other studies might have had people who were inhaling glucocorticoids, and that could be a reason that they had lower cortisol levels. So this is just a table of our participant characteristics. So 42 people with long COVID, 45 with quick recovery. There's no statistical significant difference in the ages, in the sex, and the BMI, or the number of months since acute COVID-19. But you can see there are small trends. There's a trend for age and a trend for months since acute COVID-19. There's the number of current symptoms is clearly a lot larger in long COVID, and the number of clinic visits, this was actually surprising to me. I wanted to use this as kind of an assessment about how significant their long COVID was to them. So the median number of clinic visits for long COVID was 25, which I thought was an astounding number. And then we also, with Alba's help, because she also runs an MECFS clinic, we also did formal MECFS surveys, and 57% of our long COVID people met the criteria for MECFS. So we did ACTH stimulation testing. We did the high dose, which is kind of the standard dose of ACTH injection, and then measured in the blood the cortisol levels at 30 and 60 minutes post-injection. These were all pretty much done within the same time window, like everyone kind of got their injection between 10 and 11 in the morning. And those red lines that I'm showing you there are actually that's the threshold for a normal response. So you can see that every person, whether they had long COVID or they were controls, had a normal response. And on top of that, there's no significant differences between the groups in the baseline total cortisol or the post-injection cortisol. So we also measured ACTH prior to the injection. and found that there is a trend towards baseline ACTH being higher than in long COVID than controls, even if we take out that one outlier there. So that's interesting. I'll talk about that later. So the next thing we did was we wanted to look at diurnal cortisol levels. So understanding this kind of peak cortisol, which happens kind of in the first hour, either just before or in the first hour awakening. And so one kind of standard way to measure it right after awakening, 30 minutes and 60 minutes after awakening. And so these are salivary tests, so they're very easy to do. We sent these to Salometrics, which is the company that pioneered salivary cortisol measurements. So we feel confident in that assay. So there's no statistically significant differences in salivary cortisol, which again approximates free cortisol in the blood at any time point between long COVID and controls. We looked at a couple measures. We wanted to look at, okay, is peak morning cortisol, at least that we've measured here at awakening 30 and 60 minutes later, is that different? So there was a trend towards peak morning cortisols trending a little bit lower in people with long COVID. And then I told you we did cognitive testing. So we did, I think, 11 cognitive tests by phone. And the one that was significantly different was, and this was actually also significantly different in our AMFAR cohort too, was this OTM, is the oral trail making test A, which is a measure, like one measure of processing speed. And so we did see that was below kind of 100 would be like the population mean standard. So it's below 100, and it's also significantly different from our long COVID status. One thing I didn't mention was that the number of years of education was matched between the groups as well too. So everyone had on average 16 years of education. So most people were kind of at the college graduate level. And then the one, we also kind of looked at max cortisol versus some of these cognitive tests. And we actually did find that max cortisol was associated with the OTMTA standard score. So kind of the lower your processing speed, the lower your cortisol levels too, which that was interesting to us. So in summary, I think we can have a couple big conclusions, but I think this also raises, it leaves room for, subtle findings with cortisol. So for example, we find that total cortisol levels are similar in people with current long COVID and never long COVID in this first year post-infection. So to us, this means, and these are people who were never hospitalized, so to us, this means that total cortisol level in the clinic, it might not be a useful biomarker for long COVID, at least from our experience. In people with long COVID who are not on corticosteroids, we don't see frank adrenal insufficiency, and that's not driving their long COVID symptoms, we can say that. The levels of free cortisol in the hour after awakening and throughout the day are similar in people with long COVID and people who recovered quickly. Peak morning cortisol is correlated with processing speed, so that was kind of the one significant thing that fell out. There were these subtle trends that might or might not end up being significant in larger studies. This is why I'm glad other cohorts are also examining this. So looking at peak morning free cortisol, it's not statistically significantly lower, but there was a trend there. So it'd be interesting to see if that is the case in larger groups. And then this mid-morning ACTH level or ACTH levels in general might be higher in people with long COVID. So I think that still needs to be worked out. So I think, larger studies are needed to determine a couple things. These are kind of the two questions that I have at the end of the study. So since we only looked at people who were not taking any kind of corticosteroid, it's unknown to me whether real-world corticosteroid use could be associated with reduced adrenal function and cortisol, and could that be also associated with people feeling a little bit more fatigued? So taking Sympacort because they're feeling breathless, but maybe that's actually contributing to their fatigue or a little bit to their brain fog. We clearly show that you can have severe fatigue and severe brain fog without that too, but we can't know this unless it's studied. And then the second question I have is whether the timing and magnitude of peak morning free cortisol with people in long COVID is or is not different than controls. So I think there's still a little bit of room that this might be a subtle finding that is seen in people with long COVID, and we just didn't have the numbers to tell. And I just have a lot of people to acknowledge Yuka Manabe, especially because she was able to cobble together funding to do this study, which was really fantastic. Our funders, we have the Fisher Center for Environmental Infectious Disease at Johns Hopkins, very grateful to them, and they're actually very interested in long COVID. The Henry Jackson Foundation, AMFAR, the Hopkins CFAR. Big shout out to Armand, who really ran this study, Michael and Alan, who were collaborators on the AMFAR study, and Alba for basically recruiting a lot of our patients for us. So thank you.